Hi, everyone. My name is Mintu Tarakia, and on behalf of CME Outfitters, I would like to welcome you and thank you for participating in this BriefCase series entitled Telemedicine for Non-Valvular AFib Management, Turning Bedside Manner into Website Manner. We have a great case and discussion today. Our first episode in this three-part series is titled Hearing a Heartbeat from Miles Away, Remote Detection of Undiagnosed AFib. We'll be talking about new technologies and especially how they can be useful when providing virtual care for our patients, which is something we, of course, are doing more and more now. And so, as I mentioned, I'm Mintu Tarakia. I'm an associate professor of medicine, and I direct our Center for Digital Health at Stanford University. I'm also a cardiac electrophysiologist. I now want to introduce our faculty. We have a great cast of speakers today. I first want to welcome Dr. Margot Savoy. Dr. Savoy is chair of the Department of Family and Community Medicine at the Lewis Katz School of Medicine at Temple University in Philadelphia. Welcome, Margot.
Thank you for having me.
Great for you to be here. I next want to welcome another colleague, Dr. Khaldoon Tarakji. Khaldoon is Associate Section Head of Cardiac EP at the Heart and Vascular and Thoracic Institute at the Cleveland Clinic. He's also Director of Digital Health and Telemedicine and has a variety of other leadership positions. Khaldoon, welcome.
Thank you, Mintu. Pleasure to be here.
Let's review the learning objective real briefly before we kick off and get started. And that's to evaluate digital tools that aid us in identifying undiagnosed non-valvular AFib, particularly when providing care via virtual care or telemedicine. And what we're going to do is actually start with a case vignette peppered throughout with a discussion interspersed. Dr. Tarakji is going to then give us a great presentation on the topic, and then we'll follow up that with another discussion and wrap up. So I'd like to first ask Dr. Savoy to present her case to us.
Thank you so much, Mintu. So I'd like to introduce us to Mrs. Carter. She's a 67-year-old woman who I take care of who has hypertension. Why don't we take a look at my conversation with Mrs. Carter at a telehealth visit? So Khaldoon and Mintu, what do you do next with Mrs. Carter? Like, do patients often express concerns like hers? As a cardiologist, like, what would you do next?
So that was a great real world scenario that we just saw about what happens. And this comes up in many ways. And as we think about a potential new diagnostic from a device that is with patients and not one that we have in the office, we have to think of a number of issues around their clinical care. And so I'm going to punt this back to Khaldoon, who will give us a deep dive into this. But let's get your initial thoughts, Khaldoon, on what's going through your mind.
Yeah, no, immediately. First of all, this is something that we face every day. It's not unusual. And we sometimes make the comment that we have a new diagnosis called my smartwatch syndrome. The way that you react, it depends on the patient, Margot. And in the case of Mrs. Carter, I would certainly take it seriously. And I immediately start thinking, this is a lady who's complaining of palpitation. The first thing that comes to our mind, we're very sensitive to atrial fibrillation. And this could be an opportunity to explore more, nail a diagnosis, maybe provide reassurance, but maybe it's an opportunity to pick up serious arrhythmia like atrial fibrillation early on.
Oh, thank you so much. Like, honestly, why don't we take a look at what I did next? You can tell me what you think about it. So Khaldoon and Mintu, are there other questions that you would have asked Mrs. Carter at this point? So, I mean, given the information that she shared here, what would your next steps be?
Margot, that's a great, again, real world scenario where first, of course, you have this great relationship with the patient that we're seeing in this virtual visit. And we're kind of moving through this where you're beginning to unpack what I think is a really important point, which is the context of this. And we start thinking of these alerts or notifications or data points really as clinical signs and symptoms, and really trying to unpack them around context as we think through the broader scope of AFib regarding stroke prevention, of course, first and foremost, but other assessments in terms of quality of life, risk of heart failure, comorbidities and potential triggers, as well as interventions for lifestyle modifications, all become important. But I think the way that you started this with context really is the right thing to do.
Yeah, and
Calvin,
if
your thought?
I would add, in addition to all the great points that Mintu mentioned, I think as an electrophysiologist, we always look for the electrical signature of that episode. Was it just the notification about irregular heartbeat? Did Mrs. Carter actually record an ECG? Because we know Apple Watches, they have different generations. Is it the generation that she was actually able to record and capture? Because the electrical signature that gets recorded, for us, that is what we look for to nail the diagnosis if there's any atrial fibrillation or not.
Thank you both. Let's watch the final part of the visit now. So Khaldun and Mintu, how do you talk with patients like Mrs. Carter about their need for remote heart monitoring and how telehealth is sort of changing the way you might address their concerns? For example, like what an irregular heartbeat might mean for their overall health.
So again, a great real life discussion that we just saw that you had with this simulated patient on video. And what I really like about this is all the care that can be done upstream and is needed before an evaluation or further consideration of, specialized arrhythmia care, whether it's from an electrophysiologist or others. And really, the most important thing is to really confirm the signal, to understand that this is a real diagnosis. And we're going to see more of this data from Khaldun's presentation.
Yeah, I completely agree. The one point that I would add, this is real life. And we see patients that with a different level of comfort with technology. I would embrace Mrs. Carter as somebody who's really adopting all these digital tools. She's comfortable with the video chat. She's comfortable with using these technologies. The one thing that we have to remember that we always quick to dismiss the patient's ability to adopt these technologies, and they surprise us all the time. As a matter of fact, the biggest obstacle we see from the medical community, we have different level of engagement, gaps in generation, and the obstacles sometimes come from our end, not from the patient's end. So I would encourage Mrs. Carter that we're good and we're in good shape, and I really admire her embracement to technology.
Absolutely. And I had the privilege of being one of the leaders of the Apple Heart Study, which we'll hear more about from Khaldun. But we did not predict the wave of telehealth when we designed that study, but much of what you did actually recapitulates what we did in the design of that study, which is that so much of this can be done remotely, virtually, whatever you want to call it, with telehealth. You are now at the point where you can mail gold standard medical grade diagnostics for confirmation as well. And so I think this is really an important framing of more to come, not only as it sits with Khaldun and I in EP clinic, but how much can be done, in family practice, in primary care by our allied health colleagues as well. And so Margot, thanks again for that great presentation. And what we're going to do now is turn it over to Khaldun, who's going to give a talk on remote monitoring technologies. And his talk is titled Medical Innovation in the Era of Digital Health. Take it away, Khaldun.
Thank you, Mintu. Margot, again, thank you for that wonderful example. I think Mrs. Carter is truly the example of how medical innovation has transformed over the years. We're used to the traditional model, when physicians and scientists, they work closely with industry, with tech companies. Based on needs, they come up with solutions, whether it's medication or a test or a medical device, that these go through multiple clinical trials, get FDA approval, and then they get presented to the patient by the physician. So we had a central role. And as you see now, these roles have shifted. And now you see tech companies, very innovative, both small and large, coming up with beautiful products with some clinical needs assessment and maybe some small studies, and they get FDA clearance. And all of a sudden, our patients, they come into us with these devices asking for help. So the roles certainly have shifted. And we should embrace this as a great opportunity for us to address and provide better care for our patients. So what is the need in this example? I think the topic here is about atrial fibrillation. Why is it important? the need is great. It is the most common arrhythmia affecting millions of people, and this is projected only to increase with patients living longer these days. It's only going to be increasing as far as prevalence in the United States and the world. And unfortunately, AFib still accounts for about 20% of all strokes. And it is not unusual. And it really, for us, we feel really sad when somebody presents with a stroke and only to find out that they had atrial fibrillation that they didn't know about. So the need is there and the need is great. Now, historically, tech companies were quick to respond, and we're all familiar with traditional types of monitors like the Holter 24, 48 hours, event recorders, and more recently in a patch format that will get you the answer sometimes. But now we have a wave of these new wearables and direct to consumer products. And to me, I don't see this as a competition about which monitor is better, but it's truly about who the patient is and what the indication is and what are you trying to achieve. And the way I think about it to simplify this, and by the way, this is could be complicated even for cardiologists sometimes in understanding what the monitors will do. So I can only imagine that this is not a unique issue. And it's really the four basic questions that I ask myself when I choose the type of monitor. Is the patient symptomatic or not? What is the frequency of these episodes if they are symptomatic? Am I looking for detecting AFib after a stroke because symptoms then become irrelevant? You need to detect even AFib that is asymptomatic. Or are we talking about random screening of the general public? And based on these, for example, somebody with symptomatic episodes that are frequent, daily, or multiple times in a course of a week or two, traditional monitors are great. You can get your answer quickly with a Holter or an event recorder. But we all have that patient who they get these symptomatic episodes once every few months. And we all had the patient that they have to run to the emergency room and try to get an ECG. And long and behold, by the time they hit the ER, they're back in rhythm and they could not record the episode. For these patients, I think these direct to consumer products could be of great value. And I'll share with you a couple examples. This is a 58-year-old gentleman who was having episodes of palpitations, and he actually had the Holter monitor. He had a stress test, everything came back fine, and he was dismissed as having anxiety attacks. He kept having the episodes. He was not happy, so he started using this as an example of a Cardia device. And as you can see from the picture, by placing two fingers of each hand on these two metal plates and using your smartphone, it records a rhythm strip. This is not just beats per minute, but it's actual ECG recording. And long and behold, these green dots are all normal rhythm. And then one episode that he had here in yellow, if you look at the tracing, he had atrial fibrillation. So great tool to diagnose these infrequent but symptomatic episodes, and on-demand ECG comes at a great value. Another case of 62-year-old gentleman who was actually having episodes. Again, he was overseas. And on the left side, you see a recording in normal sinus rhythm using his Apple Watch. And then when he had an episode while he was overseas, clearly you see atrial fibrillation. These are the electrical signatures, like in case of Mrs. Carter, for example. I'd love to see if she had the ability to record. And again, note the quality of these recordings. You know, the one on the left, it's clearly sinus rhythm. You see P waves. I really don't need additional type of monitors to at least establish the diagnosis of AFib that you see on the right side. These tools are becoming very sophisticated and they continue to improve. What about the AFib itself? You know, beyond the diagnosis, AFib is not just a one-time event. It's really a journey with the AFib patients. They become our patients over a long period of time. And throughout that journey, they require sometimes multiple interventions. Could be a cardioversion, could be change in medications, could be an ablation. These tools also can provide a great asset to us in helping managing the patient with AFib, not just to establish the diagnosis. And this is an example that we really actually learn from our patients about how they use these tools successfully. This was about 4 years ago with a gentleman who was 44 years old, and he had atrial fibrillation and underwent cardioversion. And because his risk of stroke, we're going to hear later about the risk of the CHAS-VAS score, his score was 0. So after a month of blood thinner, we actually stopped his blood thinner. He was on one of the direct oral anticoagulant, but he kept recording and he records daily. And one day around New Year's, he went into AFib. And as you can see in the bottom, That's the recording of the morning of that day. And then in the evening, he went into atrial fibrillation and he immediately started in the DOAC again. I had the electrical signature of exactly when the AFib started, when he was in a normal rhythm. We didn't need to do a transesophageal echo, for example, to look for clots. We just schedule him for cardioversion. So great tools to help us with the management of atrial fibrillation. Now, I'm a big fan of these tools and I can see the value, but I also give my patients the word of caution about, well, before we embrace them, you need to learn few things. We did a lot of study to get to this point, but we wanted to see if our patients are able to use these products. What is the accuracy of these automated algorithm, whether it's a smartwatch or smartphone ECG, and not to bother you with a lot of details and numbers, but here's the message that we learned from most of these studies. These devices work. They will do the job. They will record a transmission for you. And as I showed you from the quality is really sometimes great and you don't need any additional testing. The patients will adopt them. We're quick to dismiss the 70-year-old woman or a man. They're not going to be able to use it. You show them how to use it, and trust me, they will use it even better than the younger ones who are usually not that careful and they don't take it seriously. We've learned this over and over through multiple studies. But for any clinical decision that needs to be made, as I mentioned in the case of Mrs. Carter, we need that electrical signature. And not only you need the machine to tell you what the diagnosis, you need to actually do an overread and confirm the diagnosis that the machine is telling you. And let me share with you a couple examples, because I don't think any device is immune from these examples. On the left, you see an example using the Cardia device, and clearly you see sinus rhythm with PVCs that was mislabeled as atrial fibrillation. And the same thing on the right, but in the opposite way. This is an Apple Watch recording of what looks to me clearly atrial fibrillation, but it was labeled as sinus rhythm. Again, these are unusual. For the majority, they're accurate, but for still, before I commit somebody on blood thinners, for example, I really need to confirm it by actually looking at that tracing. Now, these devices, as you saw in the case of Mrs. Carter, these are of great asset to us to really conduct virtual visit and take the virtual visit to a different level, not just being a video conferencing with the patient, but also to be supported by tools. And I always think that electrophysiology, we're probably at the ahead of the curve compared to many other specialties because we have the tools to accomplish this. This is a study that we conducted at the Cleveland Clinic. We've been doing virtual visits with our patients since 2016, before the pandemic. And this is probably a unique study that will never be duplicated because this was conducted before the pandemic and before COVID-19. And we surveyed patients after they conducted virtual visit just to assess their satisfaction, which is equally important when we talk about website manner. Our patient satisfaction is of utmost importance. So as you can see from the slide, when they rated the experience with the virtual visit, the vast majority said they were able to schedule it easily. They were able to see the physician that they wanted to see. They had the ability to ask all the questions. And funny, because one of the comments that were made by patients, they actually feel that there's more eye contact because you're looking at the screen and you're not looking at the side on your desk trying to plug in the information of the visit. But the one thing that I want to highlight in this slide that the vast majority had the ability to transmit their data. And that ability to share the data is extremely important. You saw Mrs. Carter, so we need to provide Mrs. Carter with the ability, with the tools that will enable her to upload whatever she recorded to Margo so she can review and assess and make the right diagnosis and the right management. And that's what we're doing now. As you can see in this slide, this is how we conduct virtual visits, for example, after atrial fibrillation ablation procedure. So yes, I am on the monitor doing a video conference with that patient who had an ablation, but also on the other screen, I have access to all the recordings that she's been doing before and after the ablation. And actually, it is very satisfying even for us as electrophysiologists to visually see the impact of anything we're doing, or if there's any recurrence of AFib to take action and take action early. And I think it's not just about the device, but it's about the platform that you build around it, the ability to share the data and look at the data. I think it's as important as the device itself. Now, what about the patient after stroke? Well, this is a little bit different because now you really need to address any AFib, whether it's causing symptoms or not. And for that reason, you cannot rely on demand type of monitoring. And that's where the law of the land is with implantable cardiac monitor. We learned this from the Crystal AFib study that looked at AFib detection after what used to be called cryptogenic stroke. Now we call it stroke with undetermined source. And we found that with the cardiac implantable monitor, you can pick up a lot more atrial fibrillation than usual monitoring. But what about wearables and these devices? Can they replace these implantable loops? Well, with the innovation of technology and combining the features of a smartwatch or a band that is continuously looking at the pulse, not the rhythm, but at least the pulse, if it detects any irregularities through different algorithms, then it can alert the patient and ask that patient to record an ECG, and then you get the electrical signature. So by combining these two features, they're turning these on-demand tools into some form of continuous monitoring, probably not perfect, but certainly can do the job in certain circumstances when you don't have access to these implantable recorders. What about the word well? So I'm a patient who never had atrial fibrillation, never had a stroke, but I'm worried with many risk factors. This is not unusual. And what we learned in the electrophysiology literature, and most of the data come from the device data, pacemaker patients, defibrillator patients, and some other studies, both small and large. What did we learn? We learned that with patients with many risk factors, the longer you monitor, the more frequent the monitoring is, the more atrial fibrillation you're going to pick up. It could be up to 30% if you monitor for a couple of years with continuous monitoring. And we do know actually this detection of AFib correlate with incidence of embolic phenomena, including stroke. But what we don't know, which is still a gap in our knowledge, is whether intervening by placing that patient on a blood thinner would change the outcome or not. Because remember, with blood thinners, there's also the risk of bleeding. And there are many, the help is on the way with through multiple large studies trying to address exactly that same question. What do you do with the asymptomatic random episodes of AFib? How do you react? How long should the episode be before you react? But more knowledge is on the way, hopefully, and we'll find some answers. What about the worried with not any risk factors, just the general public? Well, that's probably the essence of the Apple Heart study that Mintu, you led yourself. And what I really want to draw the attention of all our audience is look at the magnitude of the study. This is a study of 500,000 individuals that were using the smartwatch. This is unheard of in the field of any clinical trials. And what we learned, this is the generation that would only send you the alert if there's any irregular pulse. 0.5% got that alert. Again, this was conducted with the generation of watch that does not have the ability for ECG recording. So they relied on sending the patient a patch to see whether they had AFib. And for those who got the patch after they got the notification, 34% got AFib confirmed. And for those who had the patch and the watch at the same time, the positive predictive value of the notification was about 84%. Indeed, they had atrial fibrillation. Now we get asked, well, what about the other 99.5% that did not get the alert? Well, this is not what the study was designed for. And we don't know how long they had the watch on or things like this. But more importantly, one of the issues that we get concerned about, what do I do with the information? It's one thing if it's somebody who's 70 years old, had a stroke, our threshold of triggering therapy is probably lower. But when you get the same notification in a healthy 40-year-old person, you pause and you think, well, what do I do with the information right now? And that is what we try to address, hopefully, with more trials. Again, similar trial, but different type of band. This is the Huawei study. Very similar concept. Again, look at the numbers, close to 200,000 and 0.2% got the notification of possible atrial fibrillation. Again, the point that I tried to make that these are not just great tools for making the diagnosis, not just great tools to manage the patients, but wonderful tools for us to fill some gaps through these mega trials that we're conducting virtually these days, and more to come, hopefully, in the future. It's important to remind the audience that we have some discrepancy between the recommendations of random screening between the two sides of the Atlantic. So in the United States, it's still the US Preventive Task Force. They do not find enough evidence to recommend ECG screening random for no reason, but that might change. Now, our European colleagues, they do recommend opportunistic screening for AFib, whether by pulse checking or ECG strip in patients who are above 65 years of age or older. Now, I mentioned the field of these mega trials is moving from just AFib detection to outcomes. And one of the studies that is already ongoing, is the Heartline Study. And the Heartline Study basically is an open invitation to any person who's 65 years or older, who's a Medicare beneficiary, to enroll. And they get randomized between receiving the Apple Watch versus no watch. And the outcome is not just AFib detection, but also some clinical outcomes, including stroke, including bleeding, and that all happens through claims database. So more knowledge to come. And again, to show you an example how the field of research is moving through these open mega trials. And I'd like to share with you a patient that came to see me in October. And I think it's a wonderful example about how things are moving and changing. This is a 70-year-old lady who unfortunately suffered a stroke. Luckily, she recovered quickly. She had actually embolectomy and full recovery. And she used a 30-day monitor that didn't show any atrial fibrillation. So by the neurologist, she was referred to me to consider implanting that implantable cardiac monitor, which is really a standard of care, what we do in these circumstances. So she comes to me, and similar to Mrs. Carter, she heard about the Apple Watch, and her son got her the watch, and she started using it. And as you can see from the screen, there are actually multiple steps. So she received a notification, she got alerted to record ECG. One thing that we missed with Mrs. Carter, we don't know whether she did that step or not, she actually recorded an ECG. But actually, it doesn't even stop at that point. So this patient of mine, she didn't even know how to access that ECG that she recorded. So a lot of us, Mintu, Margot, you probably shared this with me. We turned into the tech support in our clinic visit. I was able to capture the episode. I was able to retrieve it. And I hope you agree with me, Mintu and Margot, this is clearly atrial fibrillation. She did not need the cardiac implantable monitor to establish the diagnosis. She might need other monitors to see the burden or things like this when it comes to the management of the AFib. But as far as the diagnosis of AFib, mission is accomplished. So really, we're transforming the care of our patients from them coming to us complaining of palpitation and coming to us now, Doc, I have atrial fibrillation. Tell me, what do I need to do? Again, a great successful example, but a lot of steps needed to happen to get to that point, including the ease of use and the understanding of the findings. So my takeaway, smart devices should be an asset and should not be viewed as a burden if they are used intelligently. And it's really not about the device or what type of monitor. It's more about the indication, who the patient is, and what you are trying to achieve. And there are a lot of challenges. How do you handle the data? How do you triage the data? But the opportunities are great. One, to provide better care for our patients. And the other opportunities that we should explore is to fill these gaps in our knowledge through these big trials that could never be possible without these devices.
Khaldun, that was fantastic. Thank you for that wonderful overview. And of course, thank you, Margot, for that great patient case. There's a lot to unpack, a lot to dive deeply into. And I want to sort of start by highlighting the important points to build on. I think what we know is that these devices are here, and it doesn't matter if you're a cardiologist, EP, primary care, you're going to get patients bringing that data and those alerts to you, and you're going to have to deal with them. And because of that, it is important to understand how they work. And just like pacemakers and defibrillators, to some extent, these watches are pretty complicated. They can do a lot. And you see that in the fitness world. There is so much data, and now it's getting into healthcare. And so you saw from Khaldun a lot about the irregular rhythm detection and the ECGs, but we also have heart rate notifications that can be set. So you can have patients who opt in to alerts that look for heart rate activity discordance. They'll get a message, your heart rate was 150 while you appeared to be inactive, or it was 30. And so these are all important things. But I think what Khaldun said, an important point is you have to really treat this seriously, but also confirm it. It's not truth until you can prove it. And what we, for example, know from the Apple Heart Study is that 34% of people did have AFib on subsequent ECG testing. 1 out of 4 had AFib throughout the whole episode. Probably if they had just been checked right away, they would have had it. And so now we have these ECGs right on the devices. That helps. But you can't rely necessarily on what that ECG tells you. You have to read it. Just like the automated read on the 12 lead in the ER, that it can be wrong, and it often is, you have to verify these. So verify, then trust. And I think that's a really important finding here. My question to start with, I'll start with Khaldun, is what if the ambulatory ECG monitor is negative? Does that mean you disregard it as a false positive? What other evaluation should be done? How should you think about it, recognizing this can be paroxysmal? And what point, if at all, in this virtual care relationship might they need to come in and see you?
Yeah, all these are great questions, and there are multiple questions. But first of all, with the example that I showed you, when I have the electrical signature, and if the goal is only, is this AFib or not, I truly believe mission is accomplished. And honestly, I don't need any additional monitoring to confirm at least the diagnosis of AFib. And as you know, when you have somebody who had a stroke and she's a woman and she's 70 years old, these are the points that add up. So it's not a question in anybody's mind that lady needs to be on anticoagulation. Now, in the case of Mrs. Carter, or a lot of patients, when it's a rhythm irregularity or blood pressure cuff that read the irregular pulse, this is when you rely on additional monitoring, because like we talked about, you really need that electrical signature. And again, I will start with you kind of escalate. If you can get your answer with a 2-week monitor or a 30-day monitor, that's great. At that point, if you're still not sure about whether they have an AFib or not, and you're really concerned about the high-risk patients, you might resort to implantable cardiac monitor. I love virtual visits, but there are some essential things that, unfortunately, at this day at least, you cannot accomplish virtually. So I think a lady who's 70 years old with a new diagnosis of AFib on a smart device, in addition to talking about stroke risk and blood thinners and lifestyle modification, there's some essential things that up until this point, they're probably difficult to achieve virtually. You need to examine, you need to hear if they have any murmurs. They might need an echocardiogram to assess the left ventricular function. Is there any valve disease? Once you get, which the majority of patients, by the time they come to see the electrophysiologist, they've been through these stages. They had the echo done, they had the ECG done. So at that point, you don't need to repeat these. You already have the baseline. And at this point, at least if it's not at the beginning, for the follow-up, as we talked about, since it's not just a one-time thing, virtual visit will become great if you support it with the monitoring data.
That's fantastic. Thank you. And I think really, really good advice. And remember to our audience that a smartwatch ECG is like a limb lead 1 ECG. It's basically the same exact thing. Margot, I'm going to turn to you now and ask you a couple questions. The first is really on how do you think through sort of the continuum of possible diagnosis, probable definite diagnosis, and at what point and how might you collaborate with other specialists that may be related to this? So it could be, resistant hypertension as a factor. It could be, arrhythmia care from an electrophysiologist. Maybe this is what unmasks coronary disease and other issues. Tell me how you would advise clinicians to think through those issues.
I mean, for me, I find it really fascinating because, I mean, for all of the negative things that COVID did to us as a society, one of the positive outcomes of sort of everybody being locked down in their house and having to monitor themselves in a way that they've never done before is that I'm finding that patients are a lot more comfortable with the idea of some self-management. So that whereas before they would really been very nervous sometimes about what their blood pressure number was that they checked themselves, or what their number was they were getting on the machines they were using at home, I'm finding a lot more acceptance of them being willing to take some of that on them which for me has been super helpful, because often what will happen in the reverse is that you'll come into the office and the one day that I see you is the day you're not having AFib. And so I get the EKG and the EKG is normal, but I still have a funny feeling and I don't really know what to do with it. So now I'm stuck in this in between limbo. And now we have an opportunity to potentially, not have to go the whole step of sending them off to my specialist colleague yet. Maybe I can do something different. And if you've already got the watch on, there's no reason why I can't just use the data that you've been collecting all along anyway, which is kind of an exciting, to me, a kind of exciting space to be in. What I will tell you is that I'm not so sure that most of my primary care colleagues, and I know that for me, like, I don't know that I was actually so confident that the data was all that great. And so it was really helpful for me to be able to review the study and actually see how many people and what they were actually finding. Because I will be honest, I probably would have blown it off before, thinking that it probably is just the watch being funny, because often when you have monitors, the monitors fall off and they do things and you're not going to really find anybody's AFib. And I was shocked when I saw the results at how often it was actually accurate. And I really appreciated the verification of what was going on. And so I thought that was really valuable information and helpful to know. I think sometimes you can overestimate the idea that you're going to just get a bunch of worried well people coming in with no actual real findings, and you're getting all worked up and working up things that you didn't need to work up, or being worried about sending patients off to specialists and having things done to them. Like, no one wants to send a patient to get an implantable device if they never needed it because there was really nothing wrong. I mean, you just don't want to be that person. And so for me, I find that really helpful. I'm very excited about the telemedicine, not just for us talking to the patient, but also us being able to talk to our colleagues. So one of the things I have found to also be helpful during this COVID time is the access to be able to have that conversation. Sometimes you can have all three of us on at the same time, where you can tell me what you're looking at. I can tell you what I was worried about. The patient is there. And I think that's a fantastic thing that I hope we continue into the future.
That's fantastic, Margot. Thank you. And I think that point of going down, appropriately enough with your background, looking for zebras when there's an elephant right in front of you, I think makes a lot of sense, and really, really apt. So thanks for that perspective. I want to close with one last point to ask you on, and then we'll go ahead and wrap up. And this is the issue around health equity. Not everyone is going to have a fancy, expensive watch and a smartphone and data plans to support them. And where you practice, the kinds of patients you practice matter. And so this is a big discussion of itself that could go a couple hours. But how, and even if we suspect things or want to manage people, it can be a tall ask to say, hey, go buy this $100 device on Amazon because it's more convenient for you. And sometimes we lean back on traditional technology. And so, Margot, I'd love for you to describe from your lens and the patients you see, how you think through this. What are some of the challenges that we need to overcome in ensuring greater equity? We're not at the point where your Welcome to Medicare kit gives you these devices, and maybe that is or is not the right thing. But tell me how you think through that and what the challenges are.
I mean, so for me, this is one of those times where I think about not throwing out the baby with the bathwater. So even though I have these new fancy fingle things that can do really great data collection, it doesn't mean that that's the only thing I need. And it doesn't mean that if I don't have it, suddenly the world ends. So that what we were doing before was a good way of being able to measure. So I can have devices shipped to a patient's house. I can have them get information that's accurate and get it back to them. We can have that conversation over the phone. It doesn't always have to require a video. So there's many ways for us to be able to reach patients, even if they don't have access to all the different things that are available to them. I personally think that at some point, especially if we're going to continue moving forward with telemedicine as core to what we're doing, particularly with the chronic care management, that we are going to have to think about whether there's a certain set of devices that patients are just going to be able to have access to, or if they have certain diagnoses to get things, not unlike what we do now with congestive heart failure, where if you know that the patient has CHF, you're going to send them home with a digital scale that lets us see what their weight looks like so that we can sort of manage them ahead of time. I could easily see a day where if we're worried about a person having AFib or we know they've had a stroke, you are sending them home with the watch to be able to monitor, to be able to pull off an EKG if you're having an issue. So I think there's a space for that potentially in the future. But what I would just really have people sort of keep in mind is that just because you don't have the newfangled watch today doesn't mean that you can't diagnose the AFib, that the patient can't get the care that they need. This is just one more tool in a toolbox. And so just think about it that way. It's not that you're going to necessarily leave all the other people out in the cold because they don't have access to all of the things that maybe some people do.
Really well said. Thank you. And with that, we're going to wrap up here by reviewing some of the SMART goals we have. These are specific, measurable, attainable, relevant, and timely goals. And so remember, when evaluating patients at risk for non-valvular AFib, confirm that kind of the routine stuff, labs and beyond, are up to date, and if needed, really want to get context around their symptoms, or in this case, signs of notifications. The strategies that Dr. Tarakji outlined in terms of verification to identify and confirm risk, coupled with consumer-facing and medical devices, are things to keep in mind. As you heard from Margot, you can match the screening technology to the patient in many different ways, and so it's not about the latest and greatest. You want to provide education, reinforce the importance of healthy lifestyle for stroke prevention, something that can be delivered well, and in some cases more effectively virtually, as you counsel patients on risks and benefits. And then again, have resources ready for your patients. Those are some simple things we all do for all conditions, but I think a good reminder for all of us. And so this has really been a fantastic discussion. I want to thank our guest speakers, Dr. Tarakji and Dr. Savoy, for really a wonderful and enlightening session. Thanks again to our audience for joining us, and we hope that this was useful and that you'll be able to apply this to your practice. I encourage you to visit the Cardiology Hub on CME Outfitters at their website for additional accredited CME activities. There's also other resources that you can use and share with your patients. And again, this is the first of several vignettes that we have, so look for the other 2 case programs, again with additional outstanding speakers, and I'm sure you will enjoy them. If you have any questions or comments about our discussion, you can share them with us on Twitter using #NVAFB, or follow at CME Outfitters on Twitter, or any of us. Finally, to receive CME credit for today's program, click on the Evaluations tab to complete your post-test and print your certificate. Once again, thanks to our speakers, and thanks to all of you for joining us in this wonderful program.
Thank you, Mintu. Thank you, Margot.